Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is the aging skin, understanding the skin changes making residents more susceptible to breakdown. My name is Robin Malik, and I will be facilitating today's meeting. Please note, the information contained in this presentation is intended to provide general information but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today we are joined by Endsjo. Anna is an occupational therapist with a Master of Occupational Therapy degree from Nova Southeastern University and a Bachelor of Nutrition and Dietetics degree from the University of Delaware. Anna has worked as an occupational therapist for over 15 years, mainly with the geriatric population in a variety of treatment settings, including acute care, subacute care, outpatient, acute rehab, long-term care, and as an lymphedema certified therapist. Over the last 9 years, she has been dedicated to the betterment of the treatment of the elderly in LTC centers. Her time was focused on seating and positioning and contracture management of the nursing home residents. Through this experience, her hope is to guide other therapists, rehab directors, nurses, and administrators through blogs, webinars, and live courses to be able to do the same. And now, please welcome Anna.
Thank you, Robin, for that intro, and thank you, everyone, for attending today's course. As she mentioned, I am an occupational therapist by trade, and I have really been dedicated to the long-term care setting for over the last decade. And I really have been trying to increase awareness of geriatric issues, especially with a focus on wheelchair management. And I know that one of the hot topics right now in pretty much every setting are wounds and looking at their preventions and their interventions. And to me, if we can increase the awareness of what actually causes the wounds, then we're better off than trying to come up with an intervention at the end. And one of those ways is obviously understanding why is our geriatric population more susceptible? And the answer to that is the aging skin. So today we will do just that, and we'll take a very in-depth look at the aging skin and understand some natural age-related changes that really make our resident more susceptible. So today's objectives are going to be to name two functions of the epidermis, the dermis, and the hypodermis layers of the skin. Name two age-related changes that occur at each layer of the skin. Name and describe one difference between each stage of a pressure injury. So one thing you'll notice as I'm talking through these objectives is that I'm referring to a wound as a pressure injury. And this is something very important to understand, is that the NPUAP, which is the National Pressure Ulcer Advisory Panel, that's a mouthful, they are kind of the who's who of wounds. They are a group of physicians and nurses, therapists that really put out all the education. They come up with the definitions. They're the ones who come up with the definitions of the stages of pressure injuries. They really kind of lead us in our fight against wounds. And in about 2016, I believe, they came up with a new definition. And what I and probably you once learned to be a decubitus ulcer or a pressure ulcer, they are now calling a pressure injury. And the reason why is ulcer, the word ulcer itself kind of has the connotation of open. And they felt that was unfair because there are wounds that are not open that are very advanced and can cause a lot of harm. So they collectively decided that they would change the terminology to pressure injury. And I encourage you, I've gone to a lot of wound care conferences lately, and they are urging all doctors and therapists and nurses to change from calling it a pressure ulcer in your documentation to a pressure injury. Okay, so let's start off with some statistics. It's always good to know what we're up against in terms of numbers. So in the nursing home setting, more than 1 out of 10 nursing home residents have a pressure injury. And a stage 2 wound accounts for about 50% of those injuries. And this is actually, if you see the statistic, this is another thing that they have changed. We no longer use Roman numerals to stage pressure injuries. We just literally write stage 1, 2, 3, and 4 like I have. In a stage 2 wound, there are 3 layers of our skin, and a stage 2 wound has already affected the top 2 layers. So this is 50% of those injuries in our nursing homes. And if we don't do something about it by providing the appropriate equipment, the appropriate cushions, the back supports, the wheelchair models that we can configure to have even pressure distribution, then 50% of those wounds are going to get worse much faster. Another statistic is that residents with recent weight loss are at higher risk to develop a wound. And that really shouldn't surprise us. If you think about the type of residents that we have a ton of residents on appetite stimulants because they lose their desire to eat. We have a lot of residents that are on thickened liquids. So they're just not getting the nutritional intake and the hydration to really prevent a pressure injury from happening and then to heal a wound once does occur. And think about it. What do we need to heal a wound? We need proteins, nutrition, oxygen, and fluid. And we're already dealing with people who are compromised when it comes to their nutritional intake, so they obviously would be at a higher risk for development of wounds. Another statistic is that residents with high immobility are 11% greater risk than those without high immobility issues. So what does high immobility mean? High immobility is referring to anyone who spends most or all of their day in a wheelchair system. These are residents that slide into abnormal postures and can't get back off of them. So they're constantly putting pressures at those bony prominences under the ITs, under the sacrum, under the coccyx, and they're at higher risk for development of a pressure injury at those areas. Another important statistic to understand is that pressure injuries are 12% more prevalent among residents with bowel and bladder incontinence. And this, again, the good majority of our residents do have some type of incontinence issue. And the reason being is all cushion covers, I think I hear some background noise, all cushion covers are built with a...
Everyone could please mute their phones. I'm not sure why the mute feature on our line isn't working, but if you could please mute your phones, we'd appreciate it. Thank you.
So sorry. So a lot of the cushion covers that we, actually all the manufacturers' cushion covers are built with a high coefficient of friction, which are done purposely so that when you sit on your cushion cover, you don't just like slide out like a slip and slide. So they have a high coefficient of friction to kind of help us stick to our cushions so that we don't slide out. However, when we sit on moisture from incontinence of wounds or feces or urine, it increases that coefficient of friction. So then when the person starts sliding in their chair, like sliding down into sacral sitting or leaning over or any movement that occurs, our skin starts to stick even more, but our bone goes into movement and we start having those shearing forces, those frictional forces occurring, which makes us obviously more inclined to suffer a pressure injury. And then the last statistic should say a lot to us. And I was a rehab manager myself. I know we all have budgets, but as administrators, as DONs, as rehab directors, I know that sometimes the upfront cost for a good skin protection cushion or good back support that has skin protection properties, or buying that model of wheelchair that can allow us to configure the chair to prevent pressure right on those bony prominences can be expensive. But I promise you it's nowhere near the cost to the average cost to treat one pressure injury, which is $43,180. Okay, so what makes our residents so susceptible to wound development? Most residents in our nursing home settings are wheelchair users. It's an estimated 70 to 80% of all nursing home residents use wheelchairs as a mode of locomotion. And I will honestly say in my personal experience, if we're looking just at long-term care residents that are there for the long haul, not really taking into consideration the acute rehab patients that are there for short-term, I might even venture to say in most of my facilities, that number might even be closer to the 90%. And of that 70 to 80% that use wheelchairs, another 40 to 80% of those residents need some type of seating intervention. And if you think about that, in your mind right now, I want you to walk up and down the halls of your nursing home. How many of your residents do you see slid down in their chairs and leaning over to the side? And you see their arms hanging off or their legs hanging off of the leg rest. Any person who looks like that is in need of seating intervention because they are unable to maintain their body in a midline upright, optimal posture to prevent a pressure injury from occurring. And then the next statistic is that 2/3 of all nursing home residents use that wheelchair as their primary mode of locomotion. So most of us are dealing with people who are immobile or who have very limited mobility. Yes, they may be able to take 2 to 3 steps to their bed, to their chair, to the toilet, but they are sitting most of their day, spending most of the time in that wheelchair system, which automatically increases their risk for a pressure injury. So what makes matters even worse? We are dealing, with people at end of life. People don't come to a nursing home that don't need assistance, that don't have compromised strength and endurance and so forth. So we are dealing with people that have a lack of trunk and pelvis strength that increases their risk to fall into one of the 5 abnormal postures, which are posterior pelvic tilt, which is what we also can call sacral sitting, where someone sits right on their sacrum, anterior pelvic tilt, obliquities, which is where you see someone leaning a lot to one side, rotations, where you see someone kind of cockeyed in their chair, and then windswept deformities, which is, it looks as if all the legs have gone over to one side of the chair. And when we allow our residents to sit in these postures, they put pressures directly onto bony prominences that are at high risk for developing a wound. As well, these residents, again, don't have the strength to get back out of those postures. So they sit in those postures for prolonged periods of time, making them pretty much defenseless to the extrinsic factors of wound development, which are pressure, shear, and microclimate. The next issue that makes matters worse is that we think of that diagnosis list. Very long. We are dealing with residents with multiple comorbidities, and they have a lot of disease processes such as diabetes and vascular insufficiencies, nutritional deficiencies that really increase the vulnerability of the skin. And then lastly, we again are dealing with the end of life. And all of us are under the attack of natural occurring age-related changes that through the years, through the decades, make our skin more susceptible. So, all wounds have both intrinsic and extrinsic causes. Intrinsic causes are things that are stemming from within our bodies, things that me as a therapist probably cannot do too much to change. This is more something that's, as I said, a factor stemming from within my body that makes the person more susceptible to a wound development. So these are things that the medical team collectively are going to be able to change. The physicians, the nurses, the dietitian, the pharmacist, to really look at what is their medical management, what medication are they taking, what is their nutritional intake, and trying to change things so we can decrease these factors so that they don't have a wound developing. However, there are also extrinsic factors of wound development, which are things that are factors stemming from the outside environment, things that me as a therapist and you as a therapist can do something about through our equipment choices to really decrease the risk of a wound development. We can choose equipment that will fight against prolonged pressure, that will fight against shear, and that will fight against microclimate to decrease the risk of wound development in our elderly residents. So just to recap what those 3 extrinsic factors are, because I think they're important to talk about, because we will look very deeply at how the aging skin is more susceptible to all 3 of these. So the first extrinsic factor is prolonged pressure. And so pressure is just a continuous force applied directly on or against an area of the body, making the skin more susceptible to a pressure injury in that area. So when you're seated in a wheelchair, what are the 2 areas that are going to receive pressure? Anything that you're making contact with. So mainly the seat surface and the back surface. And direct pressure usually occurs at a bony prominence, which causes a peak pressure. And it's usually occurring along the spinous process on the back, on the ischial tuberosities or the ITs, which are your sitting bones that really kind of dig into the cushion that you're sitting on, your sacrum, which is the area, excuse my lack of better terminology, that's right above your butt crack, your coccyx, your greater trochanter, and that happens often if you're sitting someone in a chair that's too narrow, that's really putting pressure on the sides of the hips, or if you're dealing with someone that's very rotated in their chair. And so any bony prominence that's really pushing against the seat or the back, and the back or the seat are pushing back, are high at risk. And then the next extrinsic factor is what I actually call the silent extrinsic factor. And this is commonly misunderstood to be friction alone. However, shear is a combination of downward pressure that comes from gravity pushing us into the chair, pushing you really heavily into the wheelchair system. And then when the person goes into movement, it's a combination of that downward pressure plus the movement happening between the bony prominence and the skin below, causing a static friction. And so it occurs when the patient, again, is in movement. Pressure happens when we're static. Shear happens when someone is moving in their wheelchair system. And it usually occurs during weight shifts, reaching, repositioning, sliding down because they've gotten tired in their wheelchair systems. And it causes a permanent deformation of the deeper layers of skin, tissue, resulting in cell death, and then to that skin breakdown. And one more thing I actually will say about shear, a way I really describe shear that I think kind of like really gets the point home to you is think about going down a sliding board in a pair of shorts on a very hot day. So you have that downward pressure, you're going to go down that sliding board because of gravity, but your skin sticks to the sliding board as your bone still wants to go down the sliding board. So that skin sticking going in one direction, the bone going into the other direction, with that downward pressure going down the sliding board is what is causing that frictional force and that shearing force. And that kind of tearing feeling that you feel at your skin is actually shear. Okay, so microclimate. This is the third extrinsic factor that I think that most of us do understand pretty well. And microclimate is a buildup of excess heat and or moisture at the seat surface. The problem with microclimate is that it actually makes pressure and shear 5 times more dangerous when microclimate is actually present. And the reason why is when we sit on a cushion or sit against a back support that has an increase of moisture, it increases the coefficient of friction, which means that our skin will stick even more readily to it. So when the person starts sliding, you'll get even more frictional forces causing that shear. As well, when we increase the temperature, what happens to our skin is as you increase the temperature of the skin, your metabolic rate goes higher. And what happens when your metabolic rate increases? You need more oxygen for that skin and everything to continue functioning at that temperature. However, when we have pressure and shear present, we are cutting the oxygen supply off. So we have a situation where we have an increase of demand because it's hotter, but we have less of a supply. And so you will actually start to have increased risk of ischemia, the oxygen being cut off faster, and the tissue dying off even faster. The microclimate happens because, again, we overhydrate the skin, it softens the skin, it softens the connective tissue when we're exposing ourselves to increased temperature and then a lot of times to moisture, like urinary or bowel incontinence, excessive sweat, and then drainage from existing wounds. And it really takes away the natural oily barrier that we have on the top of our skin that helps lubricate our skin and to protect the skin from any type of outside damage. So why am I dedicating an entire course to teaching you about skin? And why, and all the changes that happen to skin that make us more susceptible to a wound? And the reason is because the skin is our largest organ in our body. And we learn so much about how to maintain cardiac health, how to maintain kidney health, how to maintain pulmonary health, looking at all the other organs in their systems to try to prevent someone from getting sick and increase the longevity of life, correct? So why don't we talk about the largest organ in our body? And there are 4 main functions of our skin: protection, thermoregulation, sensation, and endocrine function. But today I'm really going to focus on the protection function of our skin, how it acts as a barrier to pressure and stress and trauma and any type of environmental element to protect our deeper layers of our skin, our deeper organs, and our skeletal system. Okay, so our skin is made up of 3 layers. We have the outermost epidermal layer, and then we have our middle thickest layer, which is our dermis, and then we have our deepest, fattiest layer, which is our hypodermis. So we're going to take a good deep look at all 3 and what are their functions. So that outermost layer, again, is what we see, what we feel all day, okay? And this epidermis, this outermost layer, has a thin, oily coating, kind of like a Labrador retriever, that really protects the body from any infection, any pathogens that it comes into contact with. And it won't allow them to enter the skin to prevent infections. As well, that oily barrier really acts as a waterproof barrier. It helps preventing any excess moisture from entering, and then it also prevents much needed moisture from leaving the body. It locks in the moisture that we need so that we can keep our skin hydrated, we can prevent it from becoming dry and brittle. Some other functions of our epidermis is that it houses Langerhans cells. And you may not have known the name Langerhans cells, but you did know what the function of the Langerhans cells are. And so the Langerhans cells are cells that are right here on the top layer of our skin that have a very important immune function. So you know when you're exposed to like a bacterial infection, all of a sudden your skin turns red, and if you touch it, the skin becomes hot to touch, or if you put a pressure on your skin for too long periods of time, the skin turns red and you have a temperature change? That is due to the Langerhans cells. They are the initial warning signs to a person to tell the caregiver, to tell the residents and themselves that, woo, something's going on here, there's an infection brewing, or there's a pressure, and you need to figure out what it's coming from and remove that before damage happens. Another very important function of our epidermal layer is that it's constantly shedding away dead skin cells, replacing it with healthier skin cells so that we can maintain our skin integrity and also heal a wound. And then lastly, that endocrine function, it synthesizes vitamin D. We need to be outside. We need to get that vitamin D because our cellular function, our heart function, even our happiness depends highly on the amount of vitamin D that we have in our body. Okay, so if you notice, one thing I did not tell you that our epidermal layer has are blood vessels. Yet they need to be fed oxygen and nutrients, but we don't have any blood vessels. So that means that our dermis has to be connected very closely to our epidermis and has to be connected to our dermis that does have blood vessels in order to feed that top layer to maintain it healthy and thick. So how is it connected? Our dermal-epidermal junction is the junction right here with these white finger-like wavy projections that really lock our dermis and our epidermis together. These finger-like waves allow for the blood flow and the exchange of nutrients and oxygen to constantly feed the epidermal layer, to keep it healthy, to allow it to have that ability to shed the dead skin cells away and replenish it with healthy skin cells, to maintain our health and also to heal a wound. And it also helps to maintain our skin thickness. The thicker the skin, the more we can fight against the pressure and the shear and the microclimate. That thick dermal layer is the second layer of our skin, and it makes up for about 90% of your skin's thickness. And this is the layer of our skin most responsible for protecting against physical stress placed upon us from outside environmental elements. And our dermis is made up of a lot of very important things, but we're going to go over some of these to really have a great idea of what that dermis's function is. So the first thing on the list were fibroblast cells. And fibroblast cells produce proteins, produce that connective tissue of collagen and elastin that help maintain your skin's health and repair it after injury. So collagen, which we all know very well, is what provides our skin with its strength and its form. And that's what we lose when our skin starts kind of drooping, right? So that collagen provides the skin with its tensile strength. And tensile strength is how much stress the skin can take from downward pressure before it breaks open, okay? The elastin component is very well interwoven and organized with the collagen fibers, and you can see that right there in what I call my little waffle fries. And so they're very well interwoven with those collagen fibers, and they protect the skin by providing its elasticity. It allows the skin to give and stretch and then snap back into shape once the pressure is removed, so that our skin doesn't become distorted. It doesn't become deformed and easier to break open. Another very important property that we have to understand about the dermal layer of our skin is the viscoelastic property that it has. So our dermis has the ability to deform and give when pressure is applied. But with friction, pressure is just a downward pressure, right? But friction, you have the downward pressure plus movement. So the skin has to give in a multitude of directions when movement is occurring, okay? And so viscoelasticity is the skin's ability to stretch and move even further beyond the capabilities of the elastin fibers alone, because it takes into account the fluid component of our skin, the viscous component of our skin. So instead of just giving a little bit and being a little bit elastic, it gives a lot because it's now taking that viscous, that fluid component of our skin into account. So this is super important when understanding the skin's ability to withstand shear, because as you remember, shear happens when we're in movement in our wheelchair system. Okay, moving on, we also have the blood vessels. This is the first layer where we actually have blood vessels in our skin. And those blood vessels are very thick. They transport oxygen-rich blood and nutrients to skin cells at each layer to maintain the health, the thickness, and to provide wound healing. And they also pick up any extra toxins excreted into the lymphatic system that then are taken out of the body. As well, the blood vessels really help in temperature regulation. So when we're exposed to hot temperatures or we're exposed to cold temperatures, those blood vessels, when we are exposed to excessive heat, will actually relax and vasodilate and allow us to give off excess heat and maintain the temperature of our skin at the temperature it needs to be for optimal function. And then, just like when we're outside and it's freezing cold outside and we kind of get into a little ball, when we're exposed to excess temperatures of cold, our blood vessels constrict and become smaller so that you can retain the much needed heat for the cellular function to happen. Okay, moving on, we also have lymphatic vessels at our dermal level. And this is very important. They have a primary function to get rid of excess harmful substances from our body. It actually goes along with the blood vessels, the circulatory system. And remember, those blood vessels pick up toxins and things, that waste products, dumps it into the lymphatic system. Then the lymphatic system filters it at its lymph nodes, its filtering stations. Then it excretes what we don't need, excess toxins out through our feces, our urine, our sweat, and then it reabsorbs and dumps what we do need, nutrients that are good, back into our circulatory system to continue to feed our cells. And then as well, here at the dermal layer, we have nerve fibers. So this is where we can actually start feeling things. We start feeling the temperature of hot and cold. We start feeling pain caused by shear. We start feeling that excess pressure and the deep touch, so that we can then move off of it or tell someone to help us move off of it or cry out in pain towards a very noxious stimuli. Okay, and then the last couple things I'm going to talk about in terms of our dermis are actually very important. The sebaceous glands. So here you can see sebaceous glands on my screen, and these sebaceous glands are what produce that sebum, that oil that then is transported up through ducts and excreted onto the epidermal layer of our skin that prevents our skin from becoming dry and brittle. It lubricates our skin, keeping it moist. As well, it acts as that waterproof barrier that allows water to bead on our skin, and instead of it, allowing excess moisture to seep in and cause maceration. It also locks that much-needed moisture in to prevent our skin from becoming dehydrated, dry, and brittle. Okay, the next thing that we have in our dermis are these green sweat glands. So why do we have sweat glands? This is probably taking you back to your anatomy and physiology days. When we are exposed to excess heat, what happens? Our body starts to produce sweat here in the sweat glands. Again, the sweat travels up through ducts and then is released onto the surface of our skin, onto our epidermis, where that extra moisture can then evaporate and cool down the surface of our skin. So this is one great way how we dissipate heat. Okay, moving into the deepest layer of our skin, our hypodermis. And our hypodermis can make up to about 25% of our actual body weight. And that should be no surprise because it's mainly made up of fat cells. So if this is our largest organ covering us from head to toe, and it's made up of a lot of fat cells, then no wonder it can account for about a quarter of our body weight. As well in our hypodermis, we also have more blood vessels, deeper lymphatic vessels, deeper nerve endings to really allow that deeper layer of skin to sense pain and temperature and pressure, get rid of excess toxins, allow blood flow to maintain our skin's health. So those fat cells, they play a very, very important role in temperature regulation. They act like an insulation, much like the insulation in your homes, that will prevent excess heat from coming in and excess cold from leaving. As well, they actually act as shock absorbers. They're very much so a cushioning to that deeper tissue, muscle, and bones so that we don't have the harmful effects of pressure and trauma and shear. As well, the connective tissue in this layer of skin really anchors our skin, makes our skin nice and firm, and anchors the skin together, and not only to itself, but to the deeper fascia of the muscle and the bones, allowing us to glide over those structures. As well, those blood vessels and deeper lymphatic vessels carry blood and lymph to the deeper layers, to the tissue below, and allow all of that excretion of unneeded and then absorption of much needed products. And as well, as I said, supplying the oxygen and the nutrients between all layers of the skin to maintain its thickness, to maintain its skin integrity, and to allow for wound healing to occur. So now that we've understood what young, healthy skin looks like and what we should have in our young, healthy skin in order to help us prevent a pressure injury, let's compare young, healthy skin to aged or diseased skin, okay? And we will see this kind of cross-section from here on out, and you know that on the left-hand side, you're looking at what ideal skin should look like, and on this side of the screen, you're looking at what our geriatric population skin looks like and why they're more susceptible. Okay, so the first concept we have to understand is that all the layers of the skin become thinner. And so the overall thickness of our skin decreases by 6.4% with every decade of life after the age of 30. So I'm already into my second decade of my skin getting thinner, and I actually can really notice it. And the bad thing about that is the thinner the skin and the easier it is to actually, cause a wound or cause harm to our skin. And then we actually have a decrease in our cell turnover rate as well. So between the time we are 30 to in our 80s, it slows by like 30 to 50%. We don't shed away those dead skin cells, replace it with new skin cells, which increases our wound healing time. And you see that very often, especially in our residents with diabetes as well. It takes a lot longer for their wounds to heal. Okay, so remember those three extrinsic factors. How does it make us more susceptible? How does this thinning of our skin make us more susceptible to shear, pressure, and microclimate? Well, in terms of shear, remember this is what happens when our body goes into motion and the bone goes in one direction, the skin goes in another direction as it's being compressed down in the chair. So thicker, stronger skin can withstand greater pressure and frictional forces. So then you won't have that permanent cell deformation. You won't have the tearing of the skin cells. You won't have the tearing of the blood vessels that are very susceptible to shear forces. As well as the skin gets thinner, unfortunately, it doesn't take quite as much pressure to push down and break our skin open. Something that's thinner is going to break open much more easily than something nice and thick. And then as well with the skin, it's going to be easier to macerate. The skin is drier, it's thinner. So it's really going to be easy to allow that excess moisture that we are, sitting in from feces and urine and drainage from other wounds to really seep into that skin and macerate it. And what maceration really is, it's taking that upper epidermal layer and elevating it away from the deeper layers of your skin. So it's easier to break open, form blisters, and then those deeper layers of skin are more susceptible to then the pressure and the shear. Okay, the next change at the epidermal layer is that we have the decrease in that oil secretion. We don't have that oily barrier that lubricates the top layer of our skin, which will then equal drier, more brittle skin. So we'll be more susceptible to pressure because drier, more brittle skin cracks open much more easily than moist, lubricated skin. As well, when we lose that oily barrier, we lose the ability to lock much needed moisture in to prevent dehydration, and then when it also allows excess moisture to seep in. So you again will macerate the skin much more easily. As well at the epidermal layer of skin, we have a reduction in the number of those Langerhans cells. So remember, those Langerhans cells are our initial warning signs. They're what alert the caregiver or the resident that something's going on so that they can make a change before it permanently hurts us, okay? However, we have less. So with pressure, and we have constant downward pressure, the skin won't turn red as quickly. The skin won't have a temperature change as quickly, and so the person will have that sustained, prolonged pressure for longer periods of time before we actually make a change, before we get a better cushion, and they will break open from that pressure more easily. When it comes to microclimate, remember that when we sit in excess moisture, our urine and our feces, a lot of that is where our toxins are excreted, things that our body doesn't want, that are harmful to our body. And however, when we don't have these Langerhans cells that are changing color, the color of our skin, making our skin warmer, when we're exposing a wound bed to those types of pathogens through our urine and our feces and drainage from the wound, then we're actually increasing the risk of infections that happen to that wound bed. Okay, as well with the epidermis and the dermis, two main things that are happening is that our blood vessels become weaker. They're not as strong, they don't have as much blood flow, not as much oxygen and nutrients being transported throughout the body. The other thing is that we have a flattening of our dermal-epidermal junction. Here you see the young, healthy skin. It has a lot of surface area. Here we kind of see it flatline. It's literally kind of killing itself off. It doesn't have as much of exchange of oxygen and nutrients to maintain the skin's thickness and health. And then when we do injure the skin, our blood vessels are weaker and it's not being exchanged as well, so that our top layer of our skin dies off very quickly. In terms of shear and pressure and microclimate, those three extrinsic factors, again, it's going to make us more susceptible to them. So the deeper layers of the skin are more susceptible to shear when the top layers of the skin are thinner and dying off more quickly. As well, since the oxygen and the nutrients aren't going between the layers of the skin, you don't have as much oxygen and nutrients that are needed in order to heal a wound. Same thing with pressure. Again, with constant downward pressure, you're cutting off the oxygen supply. And again, we're in a situation where there's not as much oxygen there because the blood vessels are weaker and not carrying oxygen around. They can't transport between the layers of skin. So then you're going to have ischemia happening much quicker. The tissue will die off and break open with that constant pressure. And again, the wound healing time will be increased because you don't have the flow of oxygen and nutrients needed to heal it. And then when it comes to microclimate, when we have an increase at heat at our surface of our skin, it increases that metabolic rate that I talked about, which means we need more oxygen in order to keep functioning at that higher temperature. However, again, we're cutting off the oxygen supply, and so we have that situation of a high demand but a low supply, and then the skin tissue will die off even quicker. And as well, it's going to allow that excess moisture to seep into the skin more quickly because you have thinner layers. they're drier, and they're actually going to just absorb all that extra moisture, and maceration will happen at quicker rates. Okay, so the dermal layer. The first thing that happens, something very important, and I'm going to put a lot of stuff up on the screen, but I'm going to talk about it. I'm not going to read through it. So remember my waffle fries, and I love waffle fries. It's the collagen and the elastin that are very well interwoven that really allow us to have that tensile strength, that allow us to have that elasticity, that allows us to have that viscoelastic property to deform beyond just the elastic properties when we're thinking about the fluid content of our skin, that protects us against shear, and it protects us against just pressure alone. Well, we start to lose that. Our collagen and elastin fibers are less in number, and they become disorganized. They're no longer held together very tightly. So we lose the ability to have a lot of pressure and to give. So it'll take less pressure to break the skin open, and as we put the pressure, the skin cannot deform and snap back, so it will stay strong. And when it starts to deform, it'll stay deformed. And then you put the pressure on again, it'll deform again, and it'll deform more until it breaks open. So when we put frictional forces, when we put the downward pressure, our skin is much easier to break open. Okay, as well in our dermis, we lose the effectiveness of our nerve endings. So we just don't feel pressure. We don't feel the pain that's being caused by the shearing forces. We don't feel the temperature change and the excess heat underneath our bottom between our body and the seat surface, or between our back and the back support that we're sitting on. So it takes us longer to try to relieve the pain or relieve the pressure or even feel the frictional forces going on. And so we have a problem where we'll be under the effects of the pressure and the shear in microclimate before we actually go do something about it, because we have longer processing time of all of those different feelings. Okay, as well, in our dermal layer, remember that's where we actually house our sebaceous gland. So here in young, healthy skin, you can see it on the slide, we have plenty of sebaceous gland. Produces tons of oil that can then be released and lubricates the top layer of our skin. But as we get older, we have a decrease in number of those sebaceous glands. It decreases the amount of sebum produced, and then it decreases the ability of it to lubricate that outer layer of our skin. So in terms of pressure, our skin is more dry and brittle, and so pressure can more easily break through the skin. And then in terms of microclimate, we lose that waterproof barrier, and we will allow that excess moisture to seep in and macerate the skin more easily. As well, with the sweat glands, we have a lot fewer in number of sweat glands in aged skin. So when we're exposed to excess temperatures, we can't dissipate the heat. We can't produce the sweat that then will evaporate and cool our body down. We actually will start to absorb more heat than we give off, and then we'll be in that situation again of higher demand, lower supply, that will kill off our tissues more rapidly. And then in terms of the deepest layer of our skin, our hypodermis, we actually, something that's very interesting about our fat cells, and I think that Robin mentioned this, I'm a nutrition dietetic major in undergrad, and I'm here to tell you, unfortunately, it doesn't matter what diet you're on, the best diet in the world, you will actually never lose fat cells. But what is interesting is that as we get older, which is why we change shape as we get older, our fat cells redistribute to areas of greater surface area. So they go away from small surface areas like right under our ITs, or right under our sacrum or our coccyx, and they redistribute to greater surface areas down our thighs and more on our gluteal surfaces, and especially more to our abdomen. So we don't get rid of them, they just move away. And so when that happens and it moves away from small surface areas to greater surface areas, then when we apply downward pressure, we don't have as much of that cushion right under those bony prominences that make it more susceptible to crack open right there. As well, in terms of microclimate, we lose the insulation. Remember that another function of this fatty layer is to help with temperature regulation by keeping excess temperature out and maintain the heat that we need. So our body ends up reabsorbing more heat than it can actually dissipate, and we start having that effect. And then lastly, in this hypodermis layer, we lose the connective tissues that allow our skin to be firm. And so when we are exposed to more pressure, we lose that tensile strength. We don't need quite as much pressure to break the skin open. And so with prolonged pressure right there at the bony prominences, you're more likely to have a pressure injury occur. And then in terms of shear, remember that connective tissue is what allows us to have those fibrous bands that connects our skin together, makes our skin nice and tight in one unit that allows it to move together. As we lose the fibrous bands, the skin kind of separates from itself, and then it will start to be more susceptible to the skin going in one direction, the bone going in the other direction, and be more susceptible to those shear forces. Okay. So we need to understand what are the common areas of skin breakdown. And just think, if you're thinking of a seated posture from the wheelchair, it's anywhere where a bony prominence is digging into the back support or into the cushion. So at the ITs, at the sacrum and the coccyx are the biggest area, and along the spinous process. And then the NPUAP, again, tells us we have to then figure out what is the stage of our pressure injury. So the first concept you have to understand to know if you are actually in a state of a pressure injury is blanchable versus non-blanchable skin. And how do we figure this out? We actually have to perform a fingertip test. And so how do we do that? We actually take some skin, the skin that has turned red that makes us wonder if there's pressure there and has skin tissue damage occurred. So we put our finger in that skin and we hold it for 3 seconds, and then we remove the pressure. And if that skin stays red and there's no color change, it's still red, then it is called non-blanchable skin. However, if you perform that fingertip test and you push for 3 seconds and you remove and the skin turns white, then the skin is blanchable. And a little trick so that you can see how I always remembered this is if you actually look at the word blanchable, if I took away the H-A-B-L-E, it's actually very close to the word white in Spanish, blanco. So you want white. You want the skin to turn white when you perform this fingertip test. You want blanco. And so the blanchable skin means that, yes, pressure is present, but no tissue damage has occurred yet. So we're in the clear. Whew. All right, let's get a prevention. Let's go ahead and get a good skin protection cushion, but the damage hasn't started yet. However, if the skin is non-blanchable and you do the fingertip test and the skin stays red, then the damage to the tissue below has already occurred, and you are now dealing with a stage 1 pressure injury, okay? And so that's why, by definition, a stage 1 pressure injury is called a non-blanchable redness of intact skin. The skin is not open yet, but when you perform that fingertip test, it'll stay red. But something very important to note about a stage 1 is that this redness is a bright red. It is not a deep red. It is not a purple or a maroon. That would actually indicate more of a deep tissue injury. Okay, so let's say that you see this, but we don't get the right cushion. We don't get the right back support. We don't look at the correct configuration of the chair. And so this person then will continue with the pressure and the shear attacking them, and they move into a stage 2 pressure injury. So this is a partial thickness skin loss because it's going through 2 layers of the skin. The epidermis is completely gone, and you're partially now going through the thickness of your dermis, okay? You also may see a very clear serum-filled blister, not a blood blister, but a clear fluid serum blister. The wound bed is still pink or red and moist. You allow that pressure to continue. We don't step in and do something about it. Then we start getting into very hot water. We start going into a stage 3 pressure injury. And this is actually called a full thickness skin loss. Why? Because it goes through the full thickness of the skin. It affects our epidermal layer and our dermal layer are gone. It's cut through all the way through those 2 top layers of skin. And we are now affecting the 3rd fatty yellow layer of our skin. However, the muscle below and the bone and the tendons, they are still intact. We cannot see them. You may have undermining, which is actually the wound spreading out as it gets worse, and actually tunneling, which means it may go very deep as it gets worse. And in areas with a lot of soft tissue, like the abdomen or a glute, they can be very, very deep. And I've actually seen wounds that we can put an entire fist into. All right, so it continues to get worse. We are now dealing with a stage 4 pressure injury. And this is where the facilities are going to get into hot water. I don't know if you know this or not, but once a facility allows a stage 4 wound to occur, it must be reported. It'll go on the internet where everyone, CMS, I think, puts it up there and says this facility allowed X amount of stage 4 wounds. And that really affects your star rating. The facility can be penalized with monetary penalties. And as well, people who are thinking about putting their loved one in there, go there and check it out. If they see that they've allowed stage 4 wounds, you're probably not going to choose that facility. So a stage 4 wound is a full thickness wound, skin thickness, because it's going through all 3 layers of the skin, and tissue loss because now you're dealing with the tissue below. So the epidermis, the dermis, and the hypodermis are gone, and you are now having exposure of the muscle and the tendons and the ligaments, and then in extreme cases, the bone. You may have slough and eschar, and that slough right there is kind of that creamy colored fluid there. That may be present in the wound. And again, you may have that undermining, the spreading outward, and the tunneling, the spreading downward as it's getting worse. And when you're starting to deal with these stage 3, stage 4 wounds, it is critical that we start using high-end skin protection cushions and back supports and the appropriate configurations of chairs. Okay, another very important concept to understand is the concept of an unstageable wound. And so unstageable wounds, if you don't really know what this means, you could make a wrong decision. And I can't tell you how many times I actually got a referral from a doctor that would say, Mrs. Smith needs a new cushion due to an unstageable wound. And if I didn't know how severe an unstageable wound was, I might think a general use or a cushion that really is built for fighting against a stage 1 injury might be sufficient, and it's so not. So an unstageable wound, again, is a full thickness skin and tissue loss. So it is covered with slough and eschar. This black stuff is eschar and the slough over here on the side, which makes it, that's what gives it the fact that it's unstageable. You can't see how deep it goes. So until you remove that, until you do debridement, you really won't know the extent deep down. However, according to the NPUAP, again, the gurus, the who's who of wounds, they're saying that once the slough and the eschar is removed, a stage 3 or a stage 4 wound will be revealed when you are calling something unstageable. So that means to us, it translates that we had better get a high-end, good skin protection cushion that can treat a stage 3, stage 4 wound. And then to me, probably the scariest wound out there, a deep tissue pressure injury. Why do I say it's scary? Because this is not the typical wound that starts with a discoloration at the top of the skin at our epidermal layer. Our skin doesn't turn red. It doesn't turn a temperature change. Usually the first warning sign that a deep tissue injury is occurring is that the person complains of pain. But you look at the skin, it doesn't have a change in color. It doesn't feel hot to touch at first until it's starting to get worse. So the reason why is that, again, this is a non-blanchable. This can be intact skin or open skin. And the discoloration of the skin is not bright pink. It is a deep red. It is a maroon. It is a purple. Okay? The skin, as I said, can be intact or open. The color discoloration is non-blanchable, so it will persist with a fingertip test. And usually you'll have some type of blood-filled blister. And the reason why it is so dangerous is because it actually usually occurs from shear. And shear, as we know, happens when we have movement in our wheelchair system. And it occurs at the bone-muscle interface. So the skin and the muscle stick while the bone goes in the opposite direction when we're moving in our chair. So the damage actually occurs way down here, and it travels upward to the most superficial layer of our skin. So by the time we have the discoloration of the skin, which is the last sign, it has already gone through all the layers of skin and it is at a very advanced stage. So that's, again, why I call shear the silent extrinsic factor, because it does its damage without any really telltale signs. So the first sign, as I said, is usually that patient just complaining of constant pain and sitting. And if you know your patient is very apt to sliding and moving in their chair, we need to start thinking, ooh, maybe it's a deep tissue injury happening. And before I allow it to get to its worst state possible and I finally see the discoloration, let me change the person's cushion, let me change their back support, and so forth. Okay, so the last thing that I want to leave you with is know the role of your therapist in regards to wound care in your long-term care setting. We need to start asking better questions on our quarterly screens, on our annual screens, and upon admissions. Instead of asking, are they still ambulating 200 feet? Are they still feeding themselves? Look to see if they're sitting in abnormal postures. Look to see if they're complaining of pain that might be your indication that someone is having a wound caused by shear. Understand those age-related skin changes that naturally are making our population, who we're taking care of, more susceptible than anyone else, okay? So that we can then pick up our residents with the goal to choose the right equipment, provide the appropriate wheelchair model that can allow us to configure seat to back angle, armrest height adjustability, to really choose good skin protection cushions, choose the appropriate back support that will allow for even pressure distribution and stabilization to prevent unwanted movement, and any needed accessory with the goals to optimally stabilize and align the person's trunk, their pelvis, and lower extremities so that we can protect our residents against those extrinsic factors of wound development. So that wraps up today's course. I hope you have enjoyed it. I know you learned a lot of probably more anatomy physiology, but it's important. It's important to understand what is going on in our elderly patient's body so that we can then make better choices and have prevention versus intervention. So I can now open it up to questions and answers. Robin?
All right. Thank you so much, Anna, for that valuable information. The one question that came in so far is, could properly hydrating these residents help cut down on some of the skin issues?
Yes, absolutely. Because one of the things that happen is our skin is we're not as hydrated. And so the more we hydrate ourselves, the more we're supplying, back into a system that's already lost the hydration, already lost the ability to have the nutrients. So yes, proper hydration is key.
All right, Anna, I think I got one more question in here. Here we go. How long does it take for the impact of improved nutrition and hydration to improve the skin?
That's a great question. I'm not really sure of the answer to that. I can try to find that for you. But I will tell you, it doesn't take long for the negative effects to happen. So just like with us, the minute, there are signs that tell us that the hydration is there now. We start urinating more. The color of our urine is different. So I think the minute you start seeing those telltale signs, the person isn't quite as lethargic, they're perking up more. So I think just be open and use your clinical judgment. When you start seeing the telltale signs that tell us that the person is hydrated is when the skin is already starting to rejuvenate itself.
One more question, Anna. What is the optimal pressure relief schedule?
Again, that is very, very individualized. Some gurus out there think, if you're using tilt and recline, that someone should change position every 15 minutes. I think that that's impossible in our long-term care setting. But I do think that we need to, instead of focusing on time, we need to start focusing on configurations of the chairs. And one thing that I'm really big on is the longer we allow them to sit at 90 degrees that our elderly bodies cannot tolerate, the more likely you are to actually have to have the need for pressure relieving techniques. When we start opening seat to back angle, when we start alleviating the pressure directly off of the pelvis, and we allow some of the pressure to then go through the back support plus the pelvis, we're using different techniques like immersion and offloading, then you probably won't need to use or reposition the person so often. But I would say a good rule of thumb and what we went for is every time that someone needed to toilet. So if they're on a 2-hour toileting schedule, definitely start trying to get them on that type of schedule for pressure relief as well. Because unfortunately in our settings, I think every 15, 30 minutes in a patient that can't do it on their own is not going to happen. So we kind of always just educated around the toileting schedules. And then, of course, as needed. If you see someone has slid down, you need to reposition them. But you will not have to reposition quite as much if we start getting the configuration of the chairs better.
Excellent. Thank you, Anna. One more question I think will actually lead us nicely into our next section here is, let's see, what cushions do you recommend for those at risk and or experiencing stage 3-4 injuries?
There are 2 types of pressure redistribution. So when you're dealing with pressure injuries, you really need to think the key word that you need to look for is pressure redistribution. So when you're reading cushions, descriptions, and so forth, that's what you're looking for. And there's 2 methods. There's offloading and there's immersion. Neither is one is better than the other. It's very individualized. So some patients immersion is better, some patients offloading is better, but it really depends. So whatever that person's, for example, someone who has a little less stability and needs something a little bit more contoured that will really lock their pelvis in place to prevent unwanted movement, and as well through the contours that you get with an offloading style cushion, it kind of gives you boundaries and borders to really align somebody optimally, then maybe they're better with an offloading style cushion. However, some people have a very odd shape. They have a lot of contractures. They have a lot of sensitivity to touch. An offloading cushion is a little harder, firmer feel. So you might want to look more for an immersion style cushion that really sinks the person in and really adds extra cushioning between the high-risk area and the person's feet because it has a softer feel. It wraps around the person's body, so you can use it with someone who has a very severe contracture or has a wound anywhere. But it's not so much, can I just say, use this cushion or that cushion? You have to think about construction. So you want to use either an offloading style cushion or an immersion style cushion. And again, it's just going to depend on what patient that you're dealing with, which system is better. And
right.
Some cushions, one more thing, some cushions actually have both. They have an immersion property that really sinks the person in and wraps around the person's contour to protect them, plus slighter, less aggressive contouring that can then give you a little bit of alignment to prevent some unwanted movement as well. So I think combination style cushions are usually kind of a safe bet.
Excellent. Thank you so much, Anna. We really appreciate your expertise. I am going to pass it over now to our senior product consultant, Kari Harbaugh, for anyone who is interested in learning about the equipment solutions that solve for shear, friction, and pressure management. Please help me to welcome Kari.
We're looking at an electric bed. So this should be something that's very common to people in long-term care. And what we know about long-term care beds is they usually come in 3 function, which means the head goes up and the knee goes up and the bed goes up and down. One of the things that Anna spoke a lot about was when someone's in a wheelchair for an extended period of time, they're sitting upright all the time. Now, if someone is bedbound, the opposite problem remains, where they're laying down all the time. So if you're going to change pressure, it's really beneficial to have a bed that has 5 functions, which means we can actually put it into a chair position from time to time. So if someone is laying flat and they have an extreme amount of pressure constantly on their shoulder blades, on their hips, and a few times a day we can sit them up into a chair position like you can see in the bottom picture there. That will help move pressure and hopefully help reduce the amount of constant pressure that is on any one part of their body. Another part that I'd like to call out here is the auto contour option on a lot of beds now. So auto contour is the ability for the bed to move the head and knees at the exact same time. So anytime we move just the head of a bed, you'll notice that the resident tends to slide down. And anytime a resident's sliding, that's bad for shear, it's bad for friction. If we can move the head and knees at the same time, we keep the resident in place a little bit better than having them slide, which then would cause the staff to have to come in and reposition them. And also, it's a much better feeling for the skin because you're not sliding, because you're not putting one part of your body up causing the rest of you to slide down. Instead, the knees going up and the head's going up at the same time, so you really stay put in the bed surface then. So I really recommend a 5-function bed anytime you have someone that is bedbound as a great way to move pressure for that resident. The next product we'll take a look at is slide sheets. We use these all the time in long-term care. Hopefully you do too. There's a variety of them made, some by Tolos, some by Hoyer. Invacare makes them. Skill Care, I believe, makes them. Just about any manufacturer out there that does any type of lifting or transferring device is going to have a slide sheet or a repositioning sheet. These are great for not just lateral transfers, but moving someone in bed, sliding them back up into bed if they've slid down. Takes the pressure off the skin, and it makes a very smooth transition to where they need to go. These are very low friction devices, so the effort that's needed from the caregiver is much, much less than it would be in the old style where we actually put like a chuck of some sort under them and lifted them up and brought them to the head section of the bed. This is just two surfaces that are very low friction that slide over each other. So if you're not using these today, certainly something to think about for repositioning and making sure that we're not causing excess stress or strain on the skin during any type of repositioning of a resident. The next item are some Panacea mattresses. Here we're going to focus on the Panacea Original and the Panacea Support mattresses. These are two of our most popular mattresses from Direct Supply. These are polyurethane mattresses, and the important thing about a polyurethane mattress is it's very breathable. A lot of times when you get a mattress, if you get something that they'll be marketed as either non-stretch, two-way stretch, or four-way stretch covers. Non-stretch is more like a vinyl material. And if you think about vinyl as you sit on a restaurant booth on a hot day and you get up and your pants are kind of damp, it's because you've been sweating and there's nowhere for that air to move. Versus two-way is going to be a little bit more breathable. Four-way is going to be very stretchy and breathable. So if you can combine a four-way stretchable cover with polyurethane foam, which is an open cell foam that allows air to come and go as the resident turns and repositions, that's going to be the best way to create a nice microclimate for the resident, which microclimate, of course, is just that little weather report between the resident and the mattress. What's going on there? Is it dry? Is it damp? What's happening? We want to make sure it's cool and dry whenever possible. So breathable materials under the resident are really, really important. When we look at layering of a foam mattress, we always layer foam mattresses so that you can get the best envelopment into the mattress as possible. So soft on top, when we slowly get more and more firm as we go down to the bottom. We want to sink in as far as possible, but we don't want one big layer of soft foam because then you'd sink all the way down and sit through the mattress or bottom out. That obviously does us no good at all. So if we can start soft and slowly get more and more firm as we go down, we can sink in, we can immerse in as far as possible without bottoming out is really ideal. So making sure you have the right foam mattress for your resident is certainly an important thing. A breathable cover on that mattress that's breathable, washable, and intact, making sure there's no rips or tears for infection control purposes is also very, very important. And know that those covers are replaceable for 90% of the mattresses out there. So take a look at those and make sure those are wearing properly for you. And last for me, but not least, is the air mattress products. So again, if we have someone that has wounds that are stage 3 or above, we really do, in accordance with the NPUAP, say we should get them on some sort of dynamic mattress. Our most popular is the Panacea Air Advance, followed by the Air Max. Now these really do two different things. The Air Advance is going to be a limited low air loss mattress. It puts out about 16 liters of air per minute. To give you an idea of what that means as far as how big this pump is, the mattress you're seeing on the top there will take about 25-30 minutes to fully inflate at 16 liters of air per minute, and then it also releases the air throughout the time it's in use. So it's limiting the amount of air that's coming out. It's doing a nice job to keep the surface cool. When we move down to the Panacea Air Max, that is our true low air loss mattress. This is going to have not just air loss, but a lot of air loss. So when we look at how many liters of air are coming out here, we're looking at 1,740 liters of air per minute. If we were to take this out of the box and put it on a bed, it'd air up completely in under 3 minutes, which is pretty incredible. The mattresses themselves are the exact same size. They both have alternating pressure. They both have a static option. We know alternating pressure is good to help increase circulation, to make sure we're moving blood, and then static is going to be used for when we want to make sure that we are equalizing the pressure on all parts of the body as much as possible. The real difference between these is the first one, the Air Advance, is a pump style, and the Air Max is a blower style. So you can get a lot more airflow coming out of that unit. The Air Max is really ideal for residents that are heavy sweaters or heavily incontinent. Outside of that may be overkill for some residents. 90% of your residents that need an air mattress could probably have a very good outcome on something like the Air Advance, leaving only about 10% to need something like the Air Max, but certainly an important product to have in the offering. With that, I believe I'm going to hand it over to Ms. Sullivan.
Yes, thank you, Kari. Now our senior product consultant, Kelly Sullivan, is going to showcase a few of our Comfort Company cushions.
Hi everyone, thanks for sticking around. I've got 2 cushions that I brought with me today. The first thing I want to talk to you about though is shear and what that means. I mean, if you can imagine yourself on a hot summer day going down a metal slide on short shorts, that's shear. You can almost hear the screech, right? And your skin sticking to that metal, that hot metal. That is a shear force that we're talking about here. Or even if you put your fingers on your skin and you push that skin, you can feel how your skin is sticking as that movement is occurring. Again, shear force. So what we're trying to do is prevent that from happening, because we know that the way cushions are made today is that there's a high coefficient in friction on cushions to help prevent you from sliding off that chair, right? That's great for keeping you staying put on the chair, but not great when we're talking about shear and the effects it has on skin integrity. So how do we solve for that? One way we can do that is by introducing technology into the cover itself. The first cushion I have here is called the Shield, which is an incredible cushion. We'll get into some details in a second, but let's focus first on the glideware technology on the cover. If you notice here, there's it's maybe a little difficult to see. Wish you all were here with me so you could touch and feel the cushion. But what I'm trying to do is demonstrate in the pelvic region here a fabric that easily moves around, so that if there's any micro movement, or if, let's say, your resident is reaching or readjusting themselves, they're not going to stick to the cushion. This property, this piece of material here, is going to move with them and allow for that movement easily, so they're not experiencing that stick that we were talking about before. So an incredible piece of technology that was built into this cushion and is available on other cushions through the Comfort Company line. This particular cushion, the Shield, has other technologies built into it. So one other issue that we find pretty common in long-term care is incontinence, right? How do we solve for moisture buildup? How do we prevent that from occurring? Well, one way of doing so is that you can't prevent incontinence perhaps, but you can help protect the integrity of the foam inside the cushion by purchasing a cushion that has an incontinence liner built into it. So this one here, the Shield, has that outer layer cover that you can experience that glideware on, and then under, if I unzipped it here, you can see the blue cover. That's an incontinence-proof cover that will keep that moisture out from actually penetrating through to the foam portion of the cushion, the actual construction of the cushion. So let's get a layer deeper here. Let's open up this cushion. Now I'm looking at foam. And you can see here there's a coccyx cutout that's going to help relieve pressure off my tailbone. I've got a carved out pelvic region, so that's going to offload pressure from my IT area. And we have contours built into the surface of the cushion that allow for abduction and adduction control. So really help with posture alignment, help with control of abduction, helps with hip rotation. I mean, there's lots of applications here for this cushion. And one of my favorite things to call out is that it actually is rated through a stage 4 wound, and it's a foam cushion. We're not really finding that to be the case in the industry. Generally, we assign air to a stage 4 wound pressure management solution when we're talking about seating surfaces. This one actually is the only one in the industry that I know of that has that rating, and it's a foam option. So it's really maintenance free. You don't have to deal with all the air and pumping up and which I think is the crux of a lot of our issue is that worry that people aren't checking the air levels appropriately. Another solution that I have in front of me here is the Vicare X series. There's a couple that I wanted to talk to today, one being the adjuster and one being the Vicare X. So both of them part of that X series. This is an alternative to the Rojo line. So if you, for instance, are experiencing some issues or you have some worry about the air levels and how your cushions are today being maintained, this is one cushion that literally you can take out of the box and you can put right onto the wheelchair and it's ready to go and is rated through that stage 4 wound. The adjuster, for instance, I think Anna was talking at the tail end of the conversation, the discussion today, about immersion. And the adjuster would definitely fit into that category of immersion because it really does allow for you to kind of sink into the surface, to cup the body to really conform to that person's shape. And then the Vicare X2 also has properties of immersion, but would be more of an offloading solution. So you can actually see that it might be a little bit more firm than you would find with the adjuster option. So all in all, the Vicare X series does have some unique properties built into it. One being, if you can see here, there's a lot of different little compartments here. So what I can do with this line is I can literally take little air cells out, and I'll actually take one out to show you, from the little compartments here. If you can see, they kind of look like little sour cream packets. And some of you that have these are probably pretty familiar with these sour cream packets. But what that does is allow for you to adjust the contours of the surface of the cushion so you can adjust it to fit the needs of the resident's positioning. So if the person, let's say, needed a coccyx cutout, on this one here, the Vicare X that I have in front of you, I can take out air from this pocket here to create a coccyx cutout. Let's say there's some lateral leaning happening. Let's put some more air cells on one side and take out some of the others. So I'm helping to put that individual back into a more centralized location on the seated surface. If there's some anti-thrust, properties that you're looking for in this, all I'd have to do is add to the front of the cushion here, and then take out air cells from the back, so I create that shelf for the anti-thrust property. The other nice thing is that this can be thrown in the wash. It's machine washable. Pretty cool when we're talking about maintenance, once again, and easeability. And then these cushions, you can see, also have the glide wear built into the cover. So we have that nice mitigation of shear that helps with the shear forces that we've been talking about throughout this discussion today. Those are the two products that I brought with me today. I did want to highlight one other thing. Comfort Company has done a really nice job of building out a selection tool for you. So they have, you're sitting there scratching your head, I don't even know where to begin. I don't know, I've got this issue with a particular resident I'm working with and I'm not sure where to go from here. I know what's happening with them, I just don't know what product might be best suited for them. They have a nice little decision tree that they've built out for you with their product line, as well as a selection guide that easily will allow you for guidance to the right solution for that individual based on whatever condition it is that you're faced with. So really nice, handy little tool for you that we can send in the email, the follow-up email. If you have any additional questions, feel free to reach out to your account manager, and they'll loop me in. We can get on a call together, or I know Anna is always available too for conferences as well. So appreciate your time today, and thank you.
Yes, thank you so much to Anna, Kelly, and Kari for that informative presentation. If you have any questions, like Kelly said, please reach out to your account manager or to us. And if you would like more information about upcoming webinars or to view past webinar videos, please visit directsupply.com/webinars. Once again, thank you for attending today.